Hello, everyone. My name is Laz Boris, and I'm the president of the Thyroid Foundation of Canada. Today, we're starting a very exciting webinar, and we have a new facilitator to, to do the work here. I'd like to introduce Michelle Spystrup, who will be your facilitator for today. Thank you.
Thank you so much, Laz. So, as he said, my name is Michelle Sveistrup, and I'm the Director of Education and Publications for the Thyroid Foundation of Canada. Um, and so I'd like to welcome you all to our February 22nd of 2026 educational webinar. And today our guest speaker is Dr. Laurent Fradet, who will be speaking on thyroid artery embolization treatment. And he is an otolaryngologist, head and neck surgeon at the CEUS de l'Estrie, Sherbrooke, and is an assistant professor at the Faculty of Medicine at the University of Sherbrooke as well in Quebec. He completed two fellowships in head and neck oncology, microvascular reconstruction at the University of Alberta in Edmonton, and also at Chris O'Brien Lifehouse in Sydney, Australia. So thyroid foundation and parathyroid surgery form a major part of his clinical practice, and he leads several research projects in this field, including studies on thyroid artery embolization for the treatment of goitres. So following this presentation, we're going to have a question and answer session. Catherine Keene, our administrator, will be acting as the producer for this webinar, and she'll be managing the technical aspects of Zoom. Therefore, if you have any technical issues during the webinar, we'd ask that you please reach out to Catherine via the chat feature. Additionally, we have Hanista Prima Chandran, our Director of Research, who will be looking after the Q&A section at the end of the presentation. And the entire webinar will be recorded and made available on our website later this week. And just before we begin, wanted to do a little bit of housekeeping. So we are using the webinar functionality of Zoom, which means that you can see and hear the presenter and the support team, but your audio and camera are not active, and we are not using the raised hand feature. As such, you're able to communicate with the other attendees using the chat feature at the bottom of the screen, so please feel free to join in. And if you don't wish to see the chat previews displayed at the bottom of the screen during the presentation, you can click on the chat button arrow and deselect the Show Chat Previews option. Additionally, please use the Q&A feature located at the bottom of your screen for your questions to the presenter only. We will not respond to the questions entered via the chat feature or from emails. Finally, please note that our webinars are presented in English, and if you wish to have any subtitles in French or any other language, you can select the CC closed caption option at the bottom of your screen, and so you can choose your preferred speaking language. I think at this point, we are ready to welcome Dr. Fradet and begin his presentation.
Thank you very much, Michelle. Thank you, Laz, also, and thank you to the whole foundation for having me this afternoon and for organizing this webinar. It's a great pleasure to be with you this afternoon to talk about thyroid artery embolization. So just to start off in terms of conflicts of interest, so I don't have any specific conflicts related to this presentation, although in the past I've been a speaker for Merck and a consultant for Sanofi. And all photos and videos from this presentation are from my practice, unless otherwise specified. They were taken with patient authorization, but please do not share it necessarily with other people for privacy purposes. So the plan of the presentation is the following. We'll start with an introduction and a little context related to goitre surgery. We'll go over the notion of percutaneous techniques, which is important to cover when we talk about minimally invasive techniques for thyroid. Then we'll jump into the subject of thyroid artery embolization, which is the main subject. We'll talk a bit about the history of the procedure description. We'll go through some cases from my practice to highlight the embolization procedure and the results. We'll talk about a few landmark studies, and then we'll discuss our current research protocol. We'll conclude and then go on with the question and the group discussion part. A little disclaimer to start off. So just to be clear, my goal today is not to position thyroid artery embolization as a new standard of care for goitres. I think there are important nuances and patient-specific factors that can only be assessed during a thorough clinical consultation for each individual patient. That being said, however, I do believe that thyroid artery embolization is a treatment option that should be discussed and offered to Canadian patients. And I think also that it is paramount for patients to be managed by a multidisciplinary team, which include endocrinology, thyroid surgeons, IR, etc. And I will present my point of view and my insight throughout the presentation as a thyroid surgeon who's familiar with thyroid artery embolization and its risks and benefits, although I do not perform the technique myself as I'm not an interventional radiologist. So who am I? Michelle covered it already, but I'm an otolaryngologist head and neck surgeon who trained at the University of Sherbrooke. I then went on to do a fellowship in head and neck surgical oncology and microvascular reconstruction in the University of Alberta, and then at the Chris O'Brien Lifehouse in Sydney. And since then, I'm an assistant professor at the University of Sherbrooke, and endocrine surgery is a major part of my practice. So just to put you in the context to start off with, so compressive goitres, so thyroid enlargements that cause compressive symptoms, has been treated with surgery for a very long time. The first successful attempt dates back to 952 AD, which was done under sedation with opium, and obviously we've come a long way since then. Thyroid surgeries is one of the thyroidectomies are one of the most common procedures done in Canada, with almost 9,000 surgeries done per year at least. And the complication rate from thyroid surgery is usually low. So if we look overall, it's about 1.5 to 3.3% complication rate related to the procedure. Obviously, the bigger the gland, the higher the complication rate, but it's important to know that overall the risk of complication related to this procedure is low. So just to point out a few cases to start off with that we've operated on. So this is an example from my practice. It's a 37-year-old male from Madagascar who came with progressive compressive symptoms, progressive thyroid enlargement. You can see that he's got quite an obvious goitre on clinical examination. Here are the scans. So on the left side, you see the CT scan of the neck. You can see that the goitre extends all the way up to the mandible and a bit even higher, that it's mainly on the left side. It shifts the larynx quite a bit on the right, and it does have a fair amount of tracheal compression that you can see here. And it has a component that goes in between the trachea and the esophagus and down in the chest. So it's quite an enlarged gland. You can see here on the right the CT scan of the chest, which shows the same features and shows a bit better that the thoracic extension of the goitre and the tracheal narrowing related to it. So, these are cases that we see in our practice, and the standard of care for these cases is surgery. So in this specific case, we were able to do the total thyroidectomy without a sternotomy, even though there was quite a significant thoracic extension. You can see here on the left, the left lobe that was taken out. On the right side, the right lobe. You can see the specimen and see the images again of the preoperative scan. So it's just to point out that even with quite large goitres, most of the time we're able to do the surgery with the cervical approach, and the rates of sternotomy and of more invasive procedures are quite low. Here's another example. So it's a 54-year-old male from Ukraine who had actually an incidental finding on chest X-ray of a thyroid nodule. You can see on the scan here, the nodule is on the right side, and it does have a fair bit of tracheal narrowing, and it goes down quite low. So it goes down to the carina and even a little bit further down than the carina. So same thing for this patient. So the standard of care is surgery. So that's what we did. We were able to bring him to OR and to do his total thyroidectomy without a sternotomy. Got the thoracic extension out, and you can see in the postoperative X-ray that the trachea has re-expanded, and the patient did well. So thyroidectomy remains our preferred treatment option in most cases of goitre, because it enables the definitive removal of all thyroid tissue, and it also enables pathology review. And we know that there's up to 23% of incidental cancers found on thyroidectomy specimens that are done for benign regions at first. So we do find a fair amount of cancer in these glands when we remove them, which is another argument for doing so, although the vast majority of these cancers will be what we call papillary microcarcinoma. So it's cancers that are less than a centimeter, and their clinical significance can be discussed. But we do find a fair amount of cancer in these specimens. So the limits, though, of thyroidectomy are the following. So obviously, patients with significant comorbidities can be less favorable surgical candidates. Also, patients' age is to be taken into account. So obviously, everybody ages differently. There's no cutoff for age in terms of being a candidate for surgery or not. However, when patient gets in their late 80s and in their 90s, you've got to really think about it. If it's a good idea to bring the patient to operation, even if they're fit. You've got to question yourself really well with these patients as to what's in their best interest. And also, obviously, even though the rate of complication, as we said, is low, there are some patients that fear the complications and that simply refuse thyroidectomy, and this is obviously a limit to this technique. So, in this context, physicians and surgeons have worked on alternatives to thyroid surgery for many years. So the main one being percutaneous ablative techniques. The current mainstay for ablation, percutaneous ablation, is radiofrequency ablation, which is very well established in some Canadian centers. However, the availability is still limited overall throughout the country. For example, here in Quebec, there's the CHUM in Montreal, which has recently acquired the equipment to do so. There's, to my knowledge, one surgeon who does it in the private setup in Montreal, and there's us who are currently trying to acquire the machine to offer this service to be covered under the public insurance. But it's still a technique whose availability is limited throughout the country. And we know also that radiofrequency ablation is less effective for large nodules. I'm not saying that it's impossible or that it's not effective, but it is less effective for nodules that are more than 5 centimeters. Also, nodules with significant mediastinal extension are less amenable to ablative percutaneous techniques, and they may require also multiple sessions in order to be efficient. Also, you've got to know that percutaneous ablative techniques are not routinely recommended by the ATA or other guidelines for non-nodular diffuse goitres. So it's really more for targeting specific nodules. So here comes thyroid artery embolization. So it was first described in 1994, and it was mainly described initially for treatment of refractory Graves' disease, and mainly in the Asian literature. So the idea was to embolize, to block the circulation the blood flow that goes to the thyroid in order to cure these patients from Graves'. What we can find out in the literature is that there's about a 71% rate of biochemical cure following this procedure, which is good. And they also found out that there was a 30 to 60% decrease in thyroid volume following artery embolization. So in this context, physicians and surgeons have started to introduce it as a neoadjuvant procedure, so as a procedure done before going ahead with thyroidectomy to minimize bleeding and also to minimize complication, mainly for goitres with mediastinal extension. And then eventually it was investigated as the sole treatment for goitres. So what's our experience with thyroid artery embolization? How has it started off in our center? So basically what happened is that there was a hallmark study done by Yilmaz from Turkey in 2021, which came to the attention of Dr. Baoubri, who's one of the interventional radiologists at our hospital, and who actually came and presented this study to our thyroid multidisciplinary tumor board group in 2022. And he mentioned to us that he'd be interested in starting to do this procedure in our hospital. And then since then, we've offered this technique as a treatment option for patients refusing surgery since about 2022. So what does the procedure look like? So it's a procedure done under conscious sedation in the interventional radiology suite. So a bit like any other or most other interventional radiology procedures. So it's not under general anesthesia, just conscious sedation. It is done in an outpatient setting. So obviously, if the patient has complications, we will admit the patient if we need to. But the vast majority will be treated in an outpatient setting. It can be done through either a femoral, so an inguinal, or a radial, so through the arm approach, depending on the anatomy and the perfusion and analysis of the radiologist and their preference. And then basically they can choose which artery or which arteries to embolize depending on the case. And the embolization is done with microcatheters that are brought in the vessels. It's done with polyvinyl alcohol particles that are between 150 and 500 microns, which is quite standard for these kind of embolization procedures. So let's go ahead with a few cases from my practice that I want to present, in order to show you what it looks like in terms of results. So the first case is a 91-year-old woman who was sent to us for a left thyroid nodule, quite large, 52 by 48 by 67 millimeters, which make it 84 milliliters in terms of volumes. And it was biopsied as benign on previous FNAs. It did grow progressively, in serial ultrasounds, and the patient was complaining of progressive dysphagia. So here are the scans for the patient. So here on the left side, you can see the coronal scan with this large nodule that has some tracheal compression related to it. You can see here on the right the axial cuts. So it's a single nodule, quite large, mostly in the neck, with a bit of a mediastinal extension, but mostly in the neck. And you can see the trachea and the esophagus being shifted on the right, similar to this nodule. And you can easily imagine that the patient will be symptomatic from this nodule. So she was offered different, things from active surveillance to percutaneous RFA techniques to surgery and to embolization, and she chose to undergo embolization. So we first get an angioscan on each of these patients to delineate the vascularity of the thyroid and to help the radiologist in selecting which artery will be embolized. So in her case, the blood flow was coming from the left inferior thyroid artery. So she underwent left inferior thyroid artery embolization with 300 to 500 microns particles in February 2023. She had some post-procedural subclinical hyperthyroidism. So it did not lead to any clinical manifestation, but her blood work showed a slight hyperthyroidism, which is quite common in these patients following embolization. On follow-up, 1 year later, her dysphagia had resolved, and she had a 69% reduction in terms of nodule volume, which is pretty good, and her TSH had normalized. And on follow-up 3 years later, she was still alive and well. The ultrasound was still pending to see if there was further volume reduction in the meantime. So here are some images of the procedure itself in order for you to see what it looks like. So these are the fluoroscopy images. So first on the left side, you can see the catheter being brought up here, and you can see the radiopacifier being injected. Here, the inferior thyroid artery has been cannulated selectively by the radiologist. You can see the feeding vessel going to the nodule, and then the radiologist is going to progressively inject the polyvinyl alcohol particles in order to occlude the vessel leading to the thyroid nodule. And you'll see progressively that as the injection goes, there's less and less blood flow going to the nodule, meaning that there's a successful embolization. So here on the right side, you can see at the end of the procedure, when we inject the radiopacifier, there's no more significant blood flow going to the nodule, which means a successful procedure. So here's her chest X-ray. So pre-intervention, you can see that there's quite a significant tracheal shift, whereas 3 years post-intervention, you see there's still a bit of a slight shift on the right side, but much less so. And here's her scan. So again, on the left here, you've got the pre-intervention scan, just to remind you again of the size of the nodule and the amount of shifting on the trachea and the esophagus that was noticeable initially. And here on the right side again, you see the almost 2 years post-intervention scan. So there's no more shift of the trachea. The nodule has greatly decreased in size. There's a 69% reduction in volume. So obviously it's still there, the nodule, but it's greatly reduced in size and the patient is asymptomatic. Here's the second case. So again, quite an elder patient, 84-year-old male with multiple comorbidities, which made him not an ideal candidate for surgery. He had a left thigh nodule, 45 by 33 by 50 millimeters, so a bit smaller. It's 37 milliliters in terms of volume, but still decent size. Benign FNAs in the past, and the patient was complaining of progressive dysphagia. And here's the pre-intervention scan. So you can see the left thyroid enlargement here. This nodule, which is, going, a fair amount of it is going in the mediastinum. And he decided to undergo thyroid artery embolization after having had the discussion of the different options. So we did the intervention in May 2023. Here's the images. Here are the images of the intervention again. So you can see the feeding vessel that goes to the goitre, to the big nodule. You can see the microcatheter being used to canalize this vessel. And then again, the polyvinyl alcohol particles being injected, with the opacification of the vessel being less and less so as the procedure goes, and eventually the feeding vessel being completely occluded by the particles. So in this case, at the 1 year follow-up, the patient wasn't complaining of any significant dysphagia anymore. His TSH had normalized, and he had actually an 83% reduction in the volume of the nodule, which is quite significant. So if you look at the pre-intervention scan on the left, just to remind you again of the size of the nodule, so you can see here, decent sized nodule. And on the right side, it's a 2 years post-intervention scan that we've got here. So you can see that the nodule, which has greatly decreased in size, 83% reduction in volume, and the patient who's now asymptomatic. So if we look at the literature on thyroid artery embolization, so if you write thyroid artery embolization in PubMed and see how many publications show up, in total, there's 357 results, the vast majority of the studies being in the last few years. Whereas, for example, if you write thyroid radiofrequency ablation, there's over 1,000 articles that show up. So it hasn't been widely studied, this subject so far. There's a landmark study on the subject, which was published in 2021 by Yilmaz. It's a group from Turkey. They reported their experience in 56 consecutive patients. Their efficacy results were evaluated at 6 months, so 6 months after the intervention. And they reported a 69% reduction in the average volume of nodules, which is quite similar to the ones that I presented to you with these two cases from our center. They report also a 56% reduction in the average thyroid volume, and a significant reduction in the ThyPro score, which is a patient-reported outcome score, which was significantly reduced after the intervention. And they reported a 98% satisfaction on the patient, which is quite high. They do report a significant rate of complications, which is important that we discuss. So minor complications are quite frequent. There's almost one patient out of two who report minor complication. These will not have, lasting implication for the patient. For example, there can be a temporary blurry vision during the procedure, temporary hoarseness, pain, and as we said before, subclinical hyperthyroidism following the intervention, which is because the thyroid partly necrosis, which leads to the release of thyroid hormones, but it's quite rare that it has clinical symptoms related to it. So these minor complications, most of them will be due to what we call non-target embolization. So you've got to know that the vessels that go to the thyroid will also nourish other nearby organs, so namely the trachea, the esophagus, through inferior thyroid artery branches. Superior thyroid artery branches can also go to the tongue, to the larynx, for example. And there's small branches that may go to the spinal cord, and obviously branches that go to the parathyroid. So these organs can be obviously affected by the embolization. In the vast majority of cases, it leads to minor temporary symptoms. Major complication rate was 3.6%. So it's not very high, but it has to be clearly understood by patients and taken into account. So what are these complications? So there was one case of inguinal hematoma, which resolved after compression, one case of symptomatic hyperthyroidism, which needed to be medicated, and one death related to a myocardial infarction secondary to the procedure. It's important to notice that there's no cases of clinically significant hypothyroidism at 6 months. So even though the patients go through most of the time a period of subclinical hyperthyroidism, eventually thyroid function goes back to normal. And it's very rare that patients will need to be on Synthroid on a long-term run compared to surgery, for example. In this study, there was no cases of stroke. This is always a complication that needs to be taken into account with endovascular procedure, because you put guide wires through arteries that irrigate also the brain, so you can either dislodge a plate that embolizes, or there can be also some embolization material which goes back in a retrograde way and leads to a stroke. So what you need to know is that there's only actually 3 cases in the Chinese literature that we could find that date before 2006. We haven't found any reports of stroke cases related to this procedure in the Western literature or since 2006. But it's obviously something to be taken into account, and which may happen with any endovascular procedure that need cannulation of the carotid artery system. So these are a few frames taken from this study, which are quite similar to our results. So you can see here that was a 45-year-old man with a 7.3 centimeter nodule who underwent embolization. Here they use a combination of coils and of PVA particles. And you can see here on the left side that the thyroid volume was quite normal. So they embolized the right side, which led to an 87% volume reduction at 6 months, and the patient was asymptomatic afterwards. Here's another example from their study. This here now is an MRI. It was a case of bilateral multi-nodular goitre, which they treated with embolization of the right superior and bilateral inferior thyroid arteries. And the patient had an 83% reduction of the right lobe and a 56% reduction of the left lobe at 6 months with no residual symptoms. So you can see that there's still a significant goitre. You've got to take into account that this is a 55-year-old man who will still live for many years, probably 40 years. So we'll need to follow these nodules with serial ultrasounds. So obviously it would not be our preferred option for this patient if he doesn't have any other comorbidities. But definitely it is an option that we may offer to this patient, and that works out. if the patient refuses other interventions. Here's another interesting study, very recent, published in January 2026 in the European Radiology Journal. It's a study from Asia. Basically, they recruited patients from January 2018 to May 2022. It was a total of 70 patients, so 53 that underwent RFA, so radiofrequency ablation for nodule, for large benign nodule, and 17 that underwent thyroid artery embolization. And their main outcome was the volume reduction rate at 6 months. And the results are that actually at 6 months in their series, thyroid artery embolization patients demonstrated a significantly higher mean volume reduction than RFA patients, especially for nodules larger than 100 millimeters, which is quite large. So, the first patient that I presented to you was 80 something milliliters. So 100 is quite large. And the complete complication rate of the thyroid artery embolization group was actually lower than the RFA group. It's 5% versus 14%. So their conclusion was that in their hands, thyroid artery embolization was more effective and had fewer complications than RFA for treatment of large benign thyroid nodules exceeding 100 milliliters. So obviously, it's not necessarily the case for smaller nodules, but it's interesting. There's a very interesting systematic review that was published in 2026 with one of the authors being a surgeon from Toronto, Dr. Pasternak. And basically, in their systematic review, they included 25 articles written in English that were published up until January 2024. So obviously, it does not include the study that I just mentioned that was published a month ago. So in total, in the systematic review, there was a total of 197 patients. And they reported that there were only 5 prospective series out of these 25 articles. So the vast majority of them being either case reports, case series, or retrospective studies. Most of these studies were done for goitre and for Graves' disease. And the vast majority of them were from China, from Poland, from Italy. In fact, if you look, there's no North American centers represented in these studies. What they found out in this systematic review is that thyroid artery embolization consistently demonstrated technical success and favorable outcomes in reducing the goitre size and symptoms. However, there are some major caveats. So the first being a lack of robust data. Second being a risk of serious complications, as we discussed earlier. And the third being the absence of standardized protocol for the intervention. So they basically conclude that thyroid artery embolization should only be considered in exceptional circumstances at specialized centers with an extensive embolization experience, which we totally agree with. And they also concluded that more trials are necessary, which is leading to our study. So basically, if you look at the clinicaltrials.gov database, which is the database for the ongoing prospective clinical trials, there's only 3 trials that are registered that mention thyroid artery embolization, with the first one being from the UK, aiming to recruit 10 patients, the second one not recruiting yet, and the third one being ours, which we will discuss further. So our research protocol aims to answer the following question. What is the efficacy and safety of thyroid artery embolization for the treatment of symptomatic goitres in a population ineligible for or refusing standard therapy? So basically, as I said, we have been doing this procedure since 2022 in our center. Beforehand, it was not part of a research protocol since it's an intervention that's already studied, already described. However, we do believe that given the paucity of results that's published in the literature, that there is an interest in getting prospective data for these patients in order to further monitor its efficacy and its safety profile, and in order to eventually extend its indication potentially. So basically, our aim is to validate the yield mass results from the study that I presented earlier on in the North American population and and setup. We aim also to standardize more of the follow-up, because in the YILMA study, the imaging follow-up protocol was not as well standardized. It was quite heterogeneous. And we aim to cover also a longer follow-up period, because we believe that 6 months is quite short in terms of study duration. We want to see the results at least at 1 year, and then potentially even follow the patients for another year or so to make sure that these results are actually lasting. So what's our primary objective? It's to evaluate the effectiveness of thyroid artery embolization to reduce the overall thyroid and the nodule volumes for the treatment of benign compressive goitres. The measures that we'll do for this endpoint is the nodule volume through serial ultrasound, and the thyroid lobe volume also. Our secondary objective is to assess the impact of TAE on the compressive and thyroid function symptoms related to the goitre, as reported by the patients. And this is very important. It will be done through patient-reported outcomes, mainly the ThyPro score, which score different domains related to thyroid symptoms. And the other secondary outcome will be the safety of the procedure that will be measured through adverse event reports, and also thyroid and parathyroid function blood work. What are the inclusion criteria for a research protocol? So if the patients do not have these inclusion criteria, it does not mean that we will not do the intervention. We may offer to have the intervention done off protocol, but in order to be added to our research protocol, we want to be sure that we standardize the procedure as much as possible. We want to be sure that we are doing the procedure to the right patient for the right reason, and also that we are not doing the procedure in nodules that will turn out to be cancers. So the inclusion criteria are the following. So patients with compressive symptoms that are attributed to the goitre, or that have significant tracheal or esophageal compression at risk of causing symptoms, and that are either ineligible for surgery or ablative treatments, or that prefer thyroid artery embolization after a thorough discussion with the patient of the different options over other treatments. It needs to be thyroid nodules that are thyroids either 1, 2, 3, or 4. So for now, we exclude patients that have thyroids 5 nodules because, again, of the higher malignancy risk with big thyroids 5 nodules. And also, we included a criteria of cytology, a bit like for radiofrequency ablation procedures. So we do accept patients that had one benign cytology result, okay? So Bethesda 2 results. And we also accept patients that have 2 different biopsies with non-diagnostic features or AUS plus. So Bethesda 1 or 3 on 2 different biopsies, or Bethesda 2 on 1 biopsy, and it needs to be adult patients. We don't offer this procedure for pediatric patients. So the exclusion criteria mirror these. So obviously patients with comorbidities that preclude endovascular procedure will be excluded. Patients with nodules that have higher risks of cancer, so thyroids 5 or Bethesda categories that are higher. Patients with uncontrolled severe hypothyroidism obviously are not candidates for the intervention because we have a significant risk of causing a thyroid storm, and children obviously are excluded from the protocol. So what does it look like in terms of implication from the patient in terms of visits? So the first visit is the baseline visit, which would be in person. It's up to 6 months before the intervention. So it's the visit where we proceed with the history of the patient, physical examination with informed consent for the research project. We do also the ThyPro and the E10 questionnaire. The E10 questionnaire is a dysphagia questionnaire. And we also make sure that the patient had the recent ultrasound, a recent CT scan of the neck and chest. If not, we can order them at that visit. And we also make sure that the patient has a baseline thyroid and parathyroid function test and has had the finally built aspiration biopsy. If it hasn't been done yet, we can do it on that day of the visit. The second visit is the intervention visit. So that takes place in the interventional radiology suites. and basically the patient will undergo the procedure, and we will record any adverse events during the intervention. Following this, typically we would do some blood work 48 hours after the intervention to monitor the possible subclinical hyperthyroidism. And the following blood work will be done according to the treating endocrinologist. So we will have an endocrinologist who follows these patients after the procedure, who monitor their blood work and determines if we need to assess them a bit quicker or not, and whether or not the patient needs to have some treatments in terms of anti-thyroid medication, cholestyramine, steroids, etc., depending on the blood work. We will do a phone follow-up 1 week after the intervention to make sure there hasn't been any other adverse events and to update on the blood work. And then the following visits can be done either in person or virtually also. We would typically get a 3, 6, and 12 months post-intervention visit. Every visit will include a questionnaire, symptom questionnaire, and also we would get an ultrasound done and blood work at each of these visits in order to monitor the volume reduction and the blood work. So we have the ethical authorization to go on with this project. We've had it since April 2025, specifically for our center, which is the Suze de l'Estrichu, based here in Sherbrooke, Quebec. And we aim for recruitment of an initial cohort of at least 20 patients, but ideally aiming to expand it to go beyond 50 patients. We have the pleasure to have participating centers that have joined us through the Canadian Society of Otolaryngology Head and Neck Surgery Collaborative Research Initiative. So it's an international study. We have one center in the US so far, the MD Anderson, which is the biggest cancer center in the world. So we're quite excited that they joined on, that they're joining in with us for this project. The Sunnybrook Center from Toronto is currently joining the process. They have not started yet, but they did have their ethics authorization very recently. Calgary will be joining in. We're in discussion with the CHUM in Montreal that's very interested in joining in. There are some other centers in Canada that are offering the procedure also to our knowledge. So we know that UHN Toronto General is offering the procedure. The VGH UBC in Vancouver is offering also the procedure, and maybe some others, but to our knowledge, these are the centers that are offering the procedure for now. So in conclusion, thyroid artery embolization is a treatment option for compressive goitres that should be discussed with Canadian patients. It does have specific advantages that may make it the preferred option in some cases for some patients, although it is not the standard of care for most cases. Its limitation and risks need to be thoroughly discussed. I think that multidisciplinary management is key with involvement of endocrinology, surgery, IR, etc. Thyroid artery embolization is currently offered in a few Canadian centers, but this will expand soon in the context of our clinical trial. And most importantly, any center that's interested in either referring patient to us or to one of the centers currently doing the procedure, or even in participating to the study and opening the study in their center is more than welcome. We would be happy to have as many centers as possible, as this, is a very selective population that we're aiming for. We think that if we can have as many centers as possible join in, it would offer the service to as many Canadian patients as possible, and would also enable us to recruit as many patients as possible in the study. So here's a few selected references specifically on the topic, which were very interesting and helped me in preparing this presentation. And here's a picture of our ENT group, part of our ENT group and residents in our annual fundraise race. And that's the city of Sherbrooke that you see here on the right side with Mount Offord in the background, which is some pretty good skiing condition this year. And thank you very much for your attention. And I'm happy to take any questions from now on.
Great. Thank you so much, Dr. Pradet, for your very interesting presentation. And like you mentioned, I think we can now go into the Q&A. So I think Hanista will be able to read the questions for you, Dr. Frade.
Perfect. Thank you.
Yes, thank you for your very informative presentation. We do have a few questions that came in, and I'm expecting more as we begin. So the first question is, will we be able to send patients that come outside of Sherbrooke and in Quebec?
Yeah, absolutely. So, we specifically for our center, any patient that has RAMQ coverage, so that is from Quebec, independently of where they live, or more than welcome to come for consultation and to discuss the procedure. For out of province patients, we're obviously happy to treat any Canadian patients. There are some certain details in terms of public insurance coverage with interprovincial, patients that would need to be addressed. To be perfectly honest, I'm not exactly sure of the logistics for this, but given that that Canadian patients are insured, throughout the country, I'm quite positive that there would be some way to get the funding for patients that would be out of province. And also, since we have quite a few centers that will be opening, so in Ontario, in Alberta, so for these patients, it will be easy to be referred in these centers. There's Toronto General that already does it, so that can cover for Ontario patients, so we haven't gone through these logistics so far for interprovincial patients here in Sherbrooke, but I'm sure there's a way to cover these interventions in some way, but it would need to be just further explored. But I'm sure there's a way to make it work.
That's great. Thank you so much. So the next question is, do you suggest a FNB of the nodules prior to embolization?
Yeah, absolutely. So a fine needle aspiration biopsy. So absolutely. So our criteria mirror pretty much the ones that are done for radiofrequency ablation. So if usually for radiofrequency ablation, people like to have two benign cytologies before going ahead. In our case specifically, we accept one benign cytology. And if the cytology is non-diagnostic, we need to have two non-diagnostic cytologies or two AUS plus cytologies. Any cytologies that have a higher malignancy risk would not typically be included. They would not be included in our research project. And typically we would be quite shy offering the intervention even off protocol to these patients. Because the reason is we just don't know, what is the evolution of these nodules that get embolized if they're cancers. There are some studies which are meaning case reports for cancers that got embolized, but it was mainly in palliative settings. So given that the procedure is not that widely spread so far, we want to be sure that we're really choosing the right patient in order to be sure that we're actually causing no harm, or the least harm as possible, because we would not like to have a patient that comes in and actually turns out to have a cancer afterwards. That being said, I did not have the experience to operate on patients that were embolized before, but it has been studied and it has been reported, to operate on patients that have been embolized. And we do it all the time for example, paragangliomas. So for other tumors, operate on tumors that have been embolized. It might cause some fibrosis. If the embolization was done with particles, it shouldn't be that bad. My experience, though, for example, with patients that had paragangliomas that were embolized with coils, this is very different, because if you embolize with coils afterwards and you try to operate on them, you try to put a clip on the vessel and to cut it, and there's a coil, it makes it very hard. So that's why also the intervention needs to be done with a team that knows what they're doing, that are experienced with these subtleties. But yeah, so definitely patients that will undergo this intervention need to have cytology before.
Thank you. And the same attendee asked who will follow up on these patients regarding the nodules. The appearance will be different on U/S post-ablation.
Yeah, exactly. So we know that the appearance of the nodules following radiofrequency ablation, for example, is very different. It might cause calcification, or features that are quite worrisome on the serial ultrasound. With embolization, it hasn't been that well described. What are the changes in terms of ultrasound appearance of the nodules? We do believe that these patients will require long-term follow-up of their nodule. We do not have a specific time frame in terms of saying, is it 5 years, is it 10 years, is it for life? I think it will be dependent on every patient. Most patients that will be undergoing this procedure will be a bit more elder. Okay, so probably that the follow-up will be less intensified as it goes on. But for example, if we were to doing it on a younger patient, I think it would probably need close to a lifetime follow-up with serial ultrasound, eventually not every 6 months, but eventually yearly or every 2 years or so. So this follow-up for the first year will be done by the research team project. So either us, if the procedure is done in Sherbrooke or Calgary or etc. And then afterwards, there would be a possibility for the follow-up to be done either with our team or through the family physician of the patient or through the endocrinology team of the patient or in the referring endocrinologist, whichever is the most suitable for the patient. But I believe that at least until we have long-term follow-up for these patients, which we do not have so far in the literature, it will need to have quite a long-term follow-up.
Right, thank you. The next question is, do you have any comments on treatment autonomous adenomas or toxic nodules?
Yeah, it's very interesting. There is literature on this, so there is mainly for Graves' disease, and about 71%, success rate, as we said. For autonomous nodules, I don't have the exact numbers in mind, but I believe that it would be probably around these in terms of success rates. So it's again, not our preferred options. We would go through discussing radioactive iodine and anti-thyroid medication and surgery at first. But in a patient who would refuse these interventions or fail these interventions for some reason, or be more wanting to have something, let's say, less invasive than surgery for more elder patients, it has been studied in the past with acceptable cure rates, but obviously not as high as surgery, obviously. But it is something that may be offered. I know that RFA also has been studied in this setup and may be offered, depending on the size of the nodule, depending also if it's more mediastinal and less amenable to radiofrequency ablation. It's something that can be definitely considered, but again, not the standard of care, obviously.
Great, thank you. So I think this might be the last question. I would be interested in bringing the procedure to Saskatoon. How can I set this up to get a IR colleague trained? Can I reach out to you?
Yeah, absolutely, with great pleasure. So you can write up on my email, which is at the screen here, laurent.fradet@usherbrook.ca. And then basically we can have our interventional radiologists be in touch with you, see if they know the team over there, be in touch with them. I believe that as I said, I do not do the procedure myself, obviously, because I'm not IR, but from the insight that I had from the IR team at our center is that it's quite straightforward for a radiologist who's used to doing embolization. Most radiologists will be used to doing embolization for example, for nosebleed, for epistaxis, and getting in these small branches of the external carotid artery. So most radiologists should be quite familiar with this setup, and I think that with putting them in touch with our team, it would be possible to expand these indication the number of centers that would offer this intervention. So we're more than happy to have our team discuss with yours if any center is interested in joining in.
Great, thank you. So that seems to be all the questions for our Q&A. Thank you to our attendees for the great questions, and thank you, Dr. Fradet, for taking the time to answer them all.
Thank you very much.
Thank you very much. I would like to thank you, Dr. Frade, for giving us an amazing presentation on thyroid artery embolization treatment. I would also like to thank our webinar team for making this educational event a success. And I'd like to put out a little mention out for any of the attendees. If you have some spare time and would like to volunteer to help others with thyroid disease virtually from your home, please don't hesitate to call us on our helpline. The phone number is 1-800-267-882 or email us at info@thyroid.ca. You can also become a member or make a donation by visiting our website at thyroid.ca. And as you exit the session, we ask that you please take a moment to complete our short survey, and you will also have the opportunity to enter your comments. Those will be used to help us improve our future webinars. And on that note, our next webinar will be on hormone replacement therapy in thyroid cancer survivors with Dr. Sana Ghaznavi on April 26th, 2026. And we hope that you can all join us then. Thank you so much.
Thank you very much.
Bye, everyone.
Bye for now.
Thank you.